Our life is precious. It is a journey from moment to moment. Because every second brings a fresh beginning. With time, rhythm comes life quality. And we find the life balance we need. When it comes to Swiss quality, rhythm of time is accurate. We craft our products to perfection. Because quality is our aim.
Good evening, ladies and gentlemen. My name is Dr. Musa Akbar. I have the pleasure and honor to chair this symposium titled The Bifurcation Tips and Tricks. And this is one of the master interventional educational classes that is organized and run by the Gulf Interventional Society. I also would like to thank Asino for sponsoring this activity. I would like to also welcome my colleagues, the panelists, Dr. Khalid Shaibi, who is a consultant interventional cardiologist in the King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia, as well as I'd like to welcome my colleague in the panel group, Dr. Abdelmajid Zubaydi, who is the president of Emirate Cardiac Society and a consultant interventional cardiologist from United Arab Emirates. I also would like to welcome our third guest speaker, as well as in the panel group, Professor Mames, whom I'll introduce in a moment after the introduction. This introduction at the end of the program, you can click on the survey and collect the certificate of attendance. So our program will start about the tips and tricks in bifurcation, followed by the two cases. And at the end, for the last 20 minutes, we will have a discussion with the questions and answers. And if you can post your questions in the chat questions so I can receive them, and then I will address the question at the end of the last case presentation. It's my great pleasure to introduce our first speaker, Professor Mames, who is the professor of cardiology in the University of Cali and served as a consultant interventional cardiologist in the Royal Stoke Hospital in UK, who will give us a talk on the tips and tricks in bifurcation PCI. So Professor Mames, the microphone is yours.
So thank you, Professor. It's a great honor to be invited by the Gulf Interventional Society and to be part of this very exciting symposium where we have some real experts on the panel and speakers. So I think it's a great opportunity to really discuss this very important subset of lesions. I'm going to focus today generally around bifurcations, but not too much on left main. So why are we having this symposium? Why are bifurcations important? Well, we can see from this slide that bifurcations are important because bifurcations are a high-risk cohort. You can see that this data from the Ultimaster registry of over 1,500 bifurcations consistently for all endpoints studied, whether it be cardiac death, target lesion revascularization, target lesion failure, the risk of these endpoints is almost double that of non-bifurcation lesions. And we classify bifurcations through the Medina classification. And this is 3 digits based on whether there's significant disease in the proximal vessel, distal vessel for the second digit, or the side branch. And you can see that bifurcations can be a number of different anatomies, and we have true bifurcations and non-true bifurcations. And the true bifurcations account for approximately half of all bifurcations that we encounter in PCI practice. More recently, we've also produced a classification with Joseph Ludwig, who's on this seminar as one of the listeners, and it's called the ABCD classification. And what this pertains to is we've given a classification based on the presence of disease in the left main, which we call A, LAD B, and circumflex C, or the intermediate D. A capital letter is given if the vessel is greater than 3.5 millimeters, and a small letter is given if the vessel is smaller than 3.5 millimeters. And so in this 111 Medina classification that you can see here in the top left, it's A, B, C in capital letters because the lesion in the left main, LAD, and circumflex are all significant and they are all greater than 3.5. Whereas in the next lesion, there's significant disease in the left main, and significant disease in the LAD, but the vessel's less than 3.5, so it's big A, small b, and capital C, and so forth. So when we're talking about bifurcation considerations, we've got to think about the anatomy, because as you can see, that there are many different types of anatomy. So we've got to think about, what is the best approach for the best patient. And really, through many randomized controlled trials, we've come to the view that provisional stent technique is considered the current gold standard for the vast majority of bifurcation lesions. I think two-stent techniques are advisable in complex lesions, particularly where there's significant side branch disease or as a bailout for provisional PCI. The optimal two-stent technique, and we're going to cover these in this seminar, will very much depend on the bifurcation characteristics. And in my view, imaging should be used for most bifurcations. So intravascular imaging is important. I think it's mandatory in left main, but ideally should be performed in all bifurcations. I think imaging is useful in that it helps us define plaque burden both in the main vessel and the side branch. It can help you define the bifurcation angle, particularly when your angiographic views are suboptimal. And I think also it provides very important information around the lesion itself. It can characterize the calcium, whether it's circumferential, the depth of the calcium, and can give you information and guidance about how to prepare the lesion before embarking on your bifurcation strategy. And this is an example of an OCT, and you can see that you can get adequate sizing of the distal vessel, the proximal vessel. You can get information about the angle of the side branch, where there's disease. You can look at the extent of calcification, whether you've prepared it adequately, and so forth. And also, finally, when you deploy your stents, you can see whether you've got good expansion, whether you've got good apposition. And this is some data that we published for left main PCI. And you can see that using intravascular imaging is associated with a marked reduction in mortality. So I think for bifurcations, you probably should use it. For left main, you definitely should use it. I think another consideration of treating bifurcations is the type of stent that you will use. Because let's not forget that if you're stenting, particularly if you're going to do pot or stenting from side branch to main vessel, there's going to be a difference in size, and you have to make sure that your stents expand to the appropriate sizes. And you can see that a 3 millimeter stent from different manufacturers will expand anywhere from 3.25 to 4.25 millimeters. And so if you have a vessel that is going from a 3 millimeter to a 4 millimeter, you can't use certain stents that are 3 millimeters. And similarly, with a 2.5 millimeter stent, if you're stenting from a side branch into main vessel, that stent will expand anywhere from between 3.25 and 3.75 millimeters. So again, stent choice is important, making sure that it adequately expands to the size that you want. So let's talk a bit about provisional stenting. So provisional stenting is relatively straightforward. Generally, if you feel that a branch is important, you should wire it. You can undertake provisional stenting through 6 French guides. And the important thing when you're deploying your stent is that you leave enough room that you can perform a pot. One of the things that sometimes trainees make the error of is use the stent that's too short, so then you don't have enough space for your balloon to do the pot adequately. Always produce a pot. And then if you would like, or if it feels that the distal side branch is compromised, you can rewire it. Now, the important thing about rewiring provisional stents is that you always go through a distal strut. And the reason that you always go through a distal strut is so that when you do the final kissing balloon, you can adequately scaffold the ostium of the side branch, whereas if you go for proximal strut, you won't get adequate scaffolding. So what I generally do is push my guide wire past the side branch and then bring it back. Then you do final kissing balloon inflation and repeat the pot. So it's pot, kiss, then pot. Now, I think for specific points with provisional, I think you should do one-to-one sizing according to distal main vessel. The stent length should be 6 to 8 millimeters proximally before the side branch, even if it is healthy vessel, because you have to have sufficient stent to be able to pot in the healthy vessel, and always pot. So it's pot, kiss, pot. And why is pot important? Well, this is an analysis that we undertook. And you can see that if you don't pot, your event rates are almost double those as if you pot. So marked increase in risk of stent thrombosis, target vessel failure, target lesion failure, target vessel AMI, whereas final kissing balloon is not so important. So generally, I don't kiss after every provisional. I only kiss if I feel that there's a compromise of the side branch. One of the things that you can sometimes encounter is when you just can't get into the side branch. You've stented across it, you've done your pot, and you just can't access your side branch. And one way around this is to advance a small balloon, maybe a 1.5 millimeter balloon, in your jailed wire, and just open up the cells to regain flow into your side branch. Then you can use another guide wire. And this is important, you have to be sure that you've passed it through your vessel and not behind the strut. And you can use that then to wire your side branch. You can then pot and then do a kissing balloon thereafter. So that's a good way of bailing out, but the important thing is to make sure that you go through the stent and not behind the stent. And if you're not sure, use imaging. So sometimes when you do provisional, you have to convert to a 2-stent technique. And really, what I do is, if I feel that the side branch is compromised, I'll do a final kissing balloon. If it looks okay, the patient's asymptomatic, I don't have a big dissection, then I leave it. If, however, the side branch is compromised, then you may need to take additional action. And the things that you think about are things like dissection, less than TIMI3 flow, ECG changes, or patient symptoms. Now, often, particularly fellows, when they see a very tight lesion at the side branch, they think immediately, oh gosh, we've got to stent it, we've got to do final kissing balloon. But when you actually do pressure wire analyses of these side branches, a significant proportion are negative. And so a lot of the time, you don't need to do this. And so you can either pressure wire to look at significance before you start embarking on 2-stent approaches, or again, imagings. If you do OCT, you can often see that the ostium looks much more favorable on OCT than it does in a 2-dimensional image that's the angiogram. So for plan 2-stent techniques, I generally do plan 2-stent techniques for big side branches where a significant part of the myocardium may be affected and disease that extends greater than 10 millimeters. And I particularly do 2-stent techniques if there's unfavorable anatomy or angulation for crossing, if the side branch did go down, if the vessel was compromised. If I'm going to do a 2-stent technique, I always prepare the lesions in the main branch and the side branch. I never, ever, ever direct stent. That's when you run into problems, particularly if you have underestimated the degree of calcification. You could end up with a complete disaster. So always adequately prepare your lesions. And so for plan 2-stent techniques, really the thing that drives me to decide how I'm going to treat them, apart from the anatomy and the angulation, is whether I have a risk of losing the side branch. If I don't, then I would either T-stent or tap or Kilot. Whereas if I am worried about losing the side branch, then I would either go for a DK crush or an inverted kilot. I don't personally use inverted tap or inverted T-stenting. So I think if you're worried about side branch going down, you don't think that you're going to be able to get back into it, go for a crush or an inverted kilot. Otherwise, these are the techniques are good. I think when you do go for a two-stent technique, go with what you're used to. Operator experience key, whatever you're comfortable. A well-performed kilot will always have better outcomes than a badly performed DK crush. So go with what you have experience in. Always ensure lesions are adequately prepared. And really the technique that you adopt will depend on your bifurcation angle, the relative sizing between the side branch and the main vessel, and the ease of side branch access that we've described, and always an image. So I'm just going to go briefly through the techniques. So DK crush, there's been a lot of work around that. So you wire the main vessel and the side branch. These are videos from Goran Stankovic. You inflate both lesions, so predilate them adequately. Sometimes they use cutting balloons. Now this is important. One of the mistakes that some people make is that they extend the side branch stent too far back. I only leave it to 2 to 3 millimeters, no further back than that. Once I've deployed the stent, I bring my balloon back slightly and then deploy at high pressure to ensure that you have good expansion at the ostium. And then I crush it with my other balloon. Take your balloon out before you crush it and then do a pot. Rewire and then do your kissing balloon and then position your stent. Again, the important thing is when you position your stent, ensure that there's enough space that you can do a pot. So again, when you deploy your stent, 6 to 8 millimeters out and pot. Now, the important thing with the final kissing balloon here is not to go to the distal cells, but to go to the proximal cells. So for all other bifurcations, like provisional bifurcations, always aim for the distal cell. The DK crush, always aim for the proximal cell. That's really important. And you finish off with the final kissing balloon and the pot. So the considerations, as we've said, is that the protrusion in the main vessel from the side branch should only be 2 to 3 millimeters maximum. The balloon of the side branch, bring it slightly back and reinflate at high pressure so you can get adequate expansion at the ostium. Don't forget to remove the wire. I've seen cases where people have crushed onto the wire, and particularly if it's a coated wire, then you can strip off the coating, and I've seen people have stent thromboses as a consequence of that. Use a 1-to-1 size main vessel balloon to crush the side branch stent. And then always when you rewire the side branch, always aim for the proximal cell, not the distal cell as you would in a provisional platform. And always finish with a pot. So tap, again, another great video from Goran Stankovic. So again, as before, wire both vessels, the main vessel and the side branch. And again, you know, it's really important to gain adequate expansion of your lesions. And one of the commonest areas of restenosis, whether it be tap or kilot or whatever technique you use, is at the ostium of the side branch because people do not adequately prepare it. So often I will use a cutting balloon, particularly in fibrocalcific disease on OCT, just to ensure adequate expansion and prevent recoil, because recoil is quite an important mechanism for not generating an adequate MLA during the procedure. So balloon both limbs, as you can see here, and then stent your main vessel. And again, the important thing is pot, so adequately size your stent and balloon based on the damage to the vessel. And again, you know, it's important for stent choice. You rewire, and you do a kissing balloon inflation, size 1-to-1 at both limbs, and you pass your stent through into the side branch. Now, the important thing here is that you don't want your stent coming too far back, but you also need to make sure that your ostium is covered, because I've seen many cases with TAP where people haven't adequately covered the ostium. So take your time in this position, go in lots of different angiographic views, ensure adequate coverage. And then again, bring the balloon back slightly, inflate, and then do a kiss. Now, the next really important thing to do is the pot. Another mistake that many people do, and again, it's really important to be really careful, increase the frame rate, just to make sure that when you do your pot, you don't do it in the segment where you've produced your tap, because then you have a risk of basically converting this into a crush and mangling your stem. So take your time, use markers, be really, really careful and do your pot, as you can see here. So again, you know, considerations: if the side branch angle is 90 degrees, T-stent's a good option. If it's not 90 degrees, then tap, but make sure you cover the ostium properly, otherwise you'll have high evidence of restenosis there. Aim for the shortest carina length possible, take your time, lots of multiple angiographic views, and the most important step, when you do your pot, make sure you don't mangle your tap. Culotte, last couple of minutes of the talk. Again, for culotte, the culotte's really best for when you have equal or similar sizes between your two side branches, and not much of a big difference between your side branch and your main vessel. If there's a huge difference, it's not a great technique. So classically, you stent into, I tend to stent into the side branch. When the culotte was originally described, it was described stenting into the main vessel. You pot, you rewire in the distal cell, you do a kiss, you deploy your stent in your side branch, in your main vessel, rewire again, pot, final kissing balloon, pot again. So every time you deploy a stent, pot to prevent malapposition, particularly when you're trying to rewire, so you don't go behind the stent. I've seen cases where people have gone behind the stent because they haven't potted, and they ended up with a complete disaster and mangled stent in the left main. And I've had to bail people out doing that. Make sure that your side branch stent can be adequately expanded to the main vessel size. And culotte may not be the optimal approach for bifurcation lesions where you have very different branch sizes. So last couple of slides. We've talked about, you know, provisional being the gold standard. One of the pieces of data that I think is quite exciting that's recently come out is the definition study. And the definition study was based on a criteria defined by Xiao Ling Chen in patients with true bifurcations, particularly those with 111 or 011. And what they looked were different characteristics and how they relate to adverse outcomes. And they defined two characteristics that increase the risk of MACE 50-fold. So the first one was distal left main bifurcation with side branch involvement of greater than 10 millimeters and significant stenosis. And the second one was the same, but with non-left main bifurcation. And then they defined other characteristics that also pertain to worse outcome. And so using this analysis, they defined as a complex bifurcation for these two types of lesions as anything with one major criteria or two minor criteria. And complex cases have much worse outcomes than simple cases. And in this analysis, initial analysis, what they showed was actually that in the complex lesions, a two-stent approach may be better than a provisional approach, but this was a retrospective analysis. And so recently, a couple of weeks ago, they published a randomized controlled trial called the Definition 2 trial, in which they took patients with these true bifurcations, so 111, 011, and complex anatomy as defined by the definition criteria. So for left main, this criteria, side branch disease of greater than 10 millimeters and significant stenosis, and for non-left main, side branch stenosis of greater than 90%, and again, lesion length greater than 10 millimeters, and any two of these minor criteria. And they randomized them to either provisional approach or two-stent strategy. And the two-stent strategy was 80% crush, 20% culotte. And these are the results, the penultimate slide. You can see that undertaking a dedicated two-stent approach in this highly specific group of patients with true bifurcations and complex lesions has much better outcomes in terms of target lesion revascularization, target vessel AMI, and target lesion failure. So, last slide in summary. I think the provisional approach should be the gold standard for most bifurcations, except for very complex bifurcations where probably two-stent techniques are better. The choice of two-stent approach, particularly for bailout, very much depends on the anatomy, the angle, the side front, and I think you should use imaging to prepare the lesion well, particularly in the ostia where most restenoses occur. So thank you for giving me the opportunity to present, and I look forward to the discussion later.
Thank you very much, Professor Mames, for a very nice, elegant presentation going over the technique, the type of techniques, and the recent literatures on definition 2. We will come to that in the discussion. So I ask you kindly to stay with us until the end. Now I'll move to my next speaker as a case presentation. And it's a pleasure to invite Dr. Ahmed Qasim. He's a consultant interventional cardiologist in King Abdulaziz University Hospital in Jeddah in Saudi Arabia, where he will present his case. So Dr. Ahmed Qasim, the microphone is yours.
I think you're on mute.
Ahmed, can you open? Yeah, can you?
Okay, sorry.
Okay. Go ahead, please.
Thank you, Dr. Musa. Thank you, GIS committee. It's my pleasure, my honor to share this case in GIS meeting. My case titled Complex Bifurcation BCI. Patient, 37 years old, male patient, with recurrent exertional chest pain, but no risk factor, no diabetes, no hypertension, and he is non-smoker. He underwent a stress test, and the result was equivocal. So he subjected for CT angio, and surprisingly, CT angio showed total occlusion of LAD after D1 and total occlusion of LCX after OM1. RCA dominant, but no significant stenosis. Echo showed the preservation of the function with grade 1 diastolic dysfunction, hypokinesia of the anterior mid-apical segment, lateral wall, and apex. He underwent coronary angiography that showed finding matched with the finding of CT angio actually. There is a mid-CTO LAD, and also very tight lesion in the ostial of diagonal branch, in addition to very tight ostial lesion in the left circumflex big OM branch. And this is right coronary artery show filling of collaterals to the left system from nearly a normal right coronary artery. And this is the left circumflex, small, appear here in the upper part of the image. So the question for this complex anatomy, BCI or CABG, and the calculation of syntax 1 and syntax 2 recommend CABG, but the patient completely refused CABG and he get shocked and crying. He refused, he's still young, 37 years old. So after hard team discussion, our strategy to go for complex high-risk bifurcation BCI. But the question, what is the definition of complex high-risk patient? Of course, we have patient factors, patient with comorbid condition, or most importantly, anatomical factors, complex anatomy like unprotected left mean, CTO lesion, complex bifurcation like our patient, or trifurcation, heavy calcification, and complex multivessel disease, or large area of myocardium at risk, in addition to the clinical presentation. And of course, according to the author, Werner, he stated that operator experience influenced decision-making and outcomes in complex cases. And also assessment of the BCI risk. We have either patient complexity in comparison to anatomical complexity of the patient is low risk anatomy and high risk comorbid condition. This is low risk BCI procedures. And if the patient have high risk anatomy and high risk comorbid condition, this is very high risk procedures. And if patient have high risk anatomy but low risk patient, this is moderate risk procedures. And complex bifurcation anatomy, by definition, complex is not just only through Medina classification, because Medina classification does not take into account bifurcation angles, lesion length, calcification, functional significance of the lesion, and all these factors are important factors for decision making. And this is the true lesion of Medina classification 111, 101, and 110. And this is very important data by the definition study in 2014, which define the definition of complexity in bifurcation. In non-left mean lesion, it is diameter stenosis, more than 90% occlusion, and the lesion length more than 10 millimeters. In addition to minor factors, and most importantly in our patient, multiple bifurcation factor, in addition to thrombus containing lesion, calcification, mean vessel length more than 25, reference diameters, and angle of bifurcation. And of course, our patient is complex anatomy. So I reviewed again the CT angio. I find in CT angio, there is no calcification in the lesion of CTO, mid-LAD. It is tapered and soft tissue. So actually it is in favor of BCI, especially antegrade approach. And also the likelihood of success according to the JCTO score, which is 0 scoring, in addition to the American College of Cardiology lesion classification, low risk scoring for this lesion, short, tapered, non-calcification. So it is also in favor of high successful antegrade approach for this CTO. So I decided to go for dual injection and antegrade approach of this CTO lesion. But when I did the dual injection, I now can assess and find the left circumflex. This is a small branch, actually. It is non-dominant and small branch. So I decided to neglect this small branch, and my strategy was neglect this small LSX and antegrade CTO BCI, and then 3-wire for the 3-vessel and sequential tab technique. So antegrade approach using Felder FC wire with support by River CTO balloon, which is one of the smallest balloon in the market, 0.75 only with 2 markers, which is excellent balloon. And eventually I succeeded to cross this very short segment of CTO by this River CTO balloon. Then incremental balloon dilatation by 2 by 15s and 2, 5, 15, and this after balloon dilatation. But I noticed that the diagonal branch is compromised after I recanalize the LAD. Probably it is the black shift to the ostium of tight diagonal branch. So I went for the diagonal branch with large balloon to 5 and inflated in this diagonal branch. And this is the anatomy after the opening of LAD and dilatation of the ostium of diagonal branch. And this is the recommendation of European guidelines for the 2-stent technique. If the side branch is 2.75 millimeter or stenosis more than 50%, or the stenosis extend more than 5 millimeter beyond ostium, or supply large area of myocardium, or anticipation of difficult in the axis. And also, this is very important for the initial strategy. If it is only focal lesion less than 3 to 5 millimeter in the side branch, so better to go for professional stent strategy. But if the lesion is more than 10 millimeter, it is better to go for 2-stent strategy. And this actually accomplished in our patient. And second most important question, which technique is better? I think there is no single technique can fit all the anatomical geometry of bifurcation lesion. But there is important factor like bifurcation angle, especially T-shaped geometry, and the angle more than 90 degrees, of course, in favor of T stenting, while in Y-shaped geometry, especially angle less than 70 in favor of crush, mini crush, keylot, and angle 70 to 80 in favor of the tab technique. So I decided to go for tab technique. Then I went for the LED first with 2.5 and by 3.8 millimeter stent at 16 atmospheric pressure. But most importantly, we should sizing the stent to the distal reference diameter actually. But we should take in consideration that the proximal part and the maximal stent expansion capacity of the stent for the proximal part when we're choosing this stent. Then I choose another stent, 3 by 23 millimeter, 16 atmospheric pressure. Then deployment of the stent with overlap zone, inflation, then both technique before D1 and both technique again before OM branch. This is a very important actually slide highlighting the black distribution at side branch ostium. We believed before that the carina have high plaque burden, and this actually was false belief. Because after imaging and OCT and IFAS, it is now clear that the burden of the plaque is high opposite to carina, not at the carina itself. So it is very important for crossing of the distal still strata, especially in tab technique, to cover this area of high plaque burden and avoid deformation of this stent if we crossing the proximal strat cell. And this is actually what I try to do in my patient. I cross by force wire to ensure crossing of this strata. Then I make exchange after that with this wire. Then I decide to go for the tab technique of diagonal with the mean branch. And this is a very important step actually to precisely locate the stent as the ostium of side branch. It is very simple technique, but need more precise detection the point of the ostium of the side branch. You can take two orthogonal views. You can change your angles to precisely locate the stent in this angle position. And this is actually what I'm doing in my patient. And then after that, I deploy, and usually and routinely I'm doing two-step high pressure balloon inflation, sequential two-step high pressure balloon inflation routinely before the final kissing balloon. Inflating the side branch first at high pressure, reaching 16, maybe 18, 20, according to each case, and then simultaneously inflating the kissing balloon, started with the side branch, then deflating both balloon with each other after that. And this is after deployment of the stent in the diagonal branch. Then I went to the second tab technique. Also precisely, I located the stent as the ostium of the side branch, left circumflex, big OM branch, and the same steps repeated again, two-step high pressure balloon inflation, then final kissing balloon for the mean vessel, left mean, and the ostium of left circumflex in addition to the OM, big OM branch. And this actually very important step, because when we have tab technique, we have a small layer of a new carina, which is actually a small metal layer. So we should be careful to not damage this small layer of carina, what we call tab zone. So in case of bot technique or kissing balloon, we should pay attention to not damaging the this small new carina actually. And this is the final results after deployment of two stent and the left mean LED crossover. Then first tab technique to diagonal branch, and the second tab technique to the left circumflex big OM branch, and I neglect the small non-dominant left circumflex branch. Patient went home. He is stable. He follow up in the outpatient clinic. He is completely asymptomatic. He follow up more than 1.5 years until in a good condition. This is lateral view for this patient actually. So TAP technique, it is a very simple technique. I'll not repeat again the steps. Dr. Mamas illustrated this clearly, but I want to highlight the two-step high pressure balloon inflation. This is very important to ensure opposing of the ostium of side branch, and also to correct the deformation of the stent in the mean vessel. And finally, kissing balloon after that and put. TAP technique is simple technique, but also there is some precaution should be taken carefully, not to jail the main vessel by too much protrusion of the side branch stent, and also not deep engagement, and there is gap, and this high risk for in-stent restenosis after that, and also don't deploy or use TAP technique in patient with a small angle less than 40, because it causing long new carina, long metal, which is actually have impact in the delay of industrialization of this long metal. So for these reasons, dedication to limit to protrusion while implanting stent is critical, in addition to the kissing balloon as well. And the concept of less metal is better. I think it is very good concept, especially for TAP technique, in comparison to the 3 layers of metal jailed by the, or crushed by mini crush technique or crush technique, especially after we adjustment the protrusion to only 1 or 2 or 3 millimeters. And this documented by Venn et al. That industrialization with single layer of new carina is better than overlapping zone 2 layers or 3 layers, and there is no delayed industrialization in patient with only single layer of metal. And this
can you summarize? Okay, can you go to conclusion because of the time?
Yeah, just 30 seconds. Yeah, I finish.
Okay.
So a definition trial, which is highlighting the importance of 2 stent strategy, routine to stent strategy, which is superior in patient with complex anatomy, and of course signified the importance of this and reduction of target lesion failure. This illustrated. So final take-home message: complex anatomy BCI is real challenge, but it is feasible with good planning. When CTO is part of complex anatomy, start by CTO lesion first. TAP technique is simple, precisely cover side branch ostium with a small stent. A sequential TAP technique is good strategy and multiple bifurcation lesion, and the concept of less metal is better. I think a good concept, but need more studies for proving this concept. And remember that hard team and good planning is the way for success, and don't put yourself in the corner like this man. Good planning first is the secret for success. Thank you very much.
Thank you very much, Dr. Ahmed Qasim. Very nice case. I'm sure there are a lot of questions coming to me. We will ask you, but because of the sake of time, I will move to the last case presentation. I would like to invite Dr. Ahmed Abdullah, who will, he's a consultant interventional cardiologist in Chest Disease Hospital in Kuwait, who will give and present his case presentation. So Ahmed Abdullah, the microphone is yours to present your case.
Thank you, Dr. Musa. Thank you, GIS, for the invitation. But please, Dr. Ahmed Qasim, I think you need to stop sharing your slides so I can share my
okay.
phone, please. Yeah. Yes, thank you. Okay, thank you for the invitation. It's really a pleasure, and appreciate all the work done by the team. My case today is a PCI of OM1, OM2 bifurcation, 2-stent strategy in patient with acute coronary syndrome. This is a This is a 38 years old male patient, slightly overweight. Risk factor, 3 risk factors actually: smoking, dyslipidemia, and positive family history. Patient presented with as a referral from peripheral hospital with acute coronary syndrome. This is 1 day before shifting to our center. Patient ECG showed sinus rhythm, dynamic T wave changes in the infralateral leads. His echocardiography showed normal ejection fraction 56%, no resting segmental wall motions, or no valvular lesions. This is patient ECG. As you can appreciate here, there is some changes in the infralateral leads. Labs without any abnormalities except for positive high sensitive troponin. Patient COVID test was negative at that time. So patient shifted to the cath lab for coronary angiography with possible intervention. Access was the right radial artery with 6 French systems. This is the summary of the coronary angiography that done to the patient. You can see the lesion in the proximal part of the LCX, followed by another bifurcation lesion between the OM1 and OM2 branches. Lesion is hazy, post-stenotic dilated segment. OM2 branch showed severe subtotal stenosis. You can see here in this view that there is some LED disease at the level of bifurcation with diagonal branch, which seems actually not to be that significant. In the RCA views, you can see dominant right coronary artery with mild proximal and mild lesion, mid lesion, sorry, followed by more distal significant stenosis with good distal runoff. So if we can summarize the coronary angiography of this patient, left system showed tight proximal and mid bifurcation lesion, OM1, OM2, Medina 1-1, hazy lesion, LED diagonal showed mild lesion, RCA showed distal tight stenosis. The decision was to do PCI to LCX OM1, OM2 bifurcation using provisional stenting approach. RCA PCI will be deferred for another session. The procedure started, as you can see here, with wiring of the 2 branches. We used the workhorse Sion wires, followed by pre-dilatation of the proximal and distal segment of the main vessel. As you can see here, ostial OM side branch actually was not dilated at this time. So just after pre-dilatation, intravascular imaging was done using OCT for petal lesion characterization and accurate vessel diameter measurement. OCT run actually was done from OM2 distally up to proximal LCX across the OM1 branch. As you can see in this image that we got from OCT, as you can see, this is clearly the intravascular thrombus here with some plaque shifting toward the OM1 ostium in this longitudinal view that compromised the OM1 ostium that happened actually most probably after pre-dilatation. And this is also the angiography following the balloon dilatation, and you can see the haziness that propagated into the ostial OM1 branch with little bit compromisation of the distal runoff of this artery. Keeping in mind here that the angle between OM1 and OM2 is less than 70 degrees. Actually, after reviewing the OCT imaging, actually I decided to change my PCI bifurcation strategy from provisional to 2-stent strategy. I putting in mind also the important technical and anatomical consideration as first the angle between OM1 and OM2, which is less than 70 degrees. Second, the access to the OM1 side branch after the first stent deployment. So according to this, in my opinion, 3 techniques could be used in this case: Kilot, tab, and crush, either mini or DK crush. So I decided my decision to go with reverse tab with the first stent deployed from the proximal LCX main branch toward OM1 side branch, followed by wire recrossing, then second stent deployment in the OM2 with minimal protrusion at the bifurcation site. I use this strategy actually mainly as I need to secure OM1 branch, which is a quite big branch supplying large lateral area, and I assume distal ciliary crossing will be easier from LCX toward OM2 rather than OM1. This view after deploying the first stent from the proximal main branch to the OM1 across OM2, putting in mind that the first stent, of course, is the beginning of our procedure. So we have to always remember that we implant a stent with uniform diameter. There is no different diameter into the bifurcation between the proximal and distal main vessel. So we need to implant the stent according to the distal vessel reference diameter and not according to the proximal main vessel diameter to avoid compromising of the side branch due to the carina shift. This is why we need to know the exact diameter, especially by imaging. Stent lengths also should be enough to cover the lesion distally, and also as mentioned by Dr. Mamas, at least to be 6 to 8 millimeter, matching the shortest available balloon. This is a very nice demonstration, from Dr. Manuel Prelakis, showing if we put a stent size according to the proximal main vessel here, then the two bad things actually can be happened. One is the carina shift, as you can see here, and I said before, which can result in stenosis or the occlusion of the ostium of the side branch. Second, the potential of the distal occlusion, of the distal dissection, that with oversized stents. This is just after the first stent deployment and before proceeded with the wire recrossing. And please always remember both as an important step before wire recrossing. As mentioned by Dr. Mamas, due to the gap between the proximal part of the stent and the main branch proximal wall, we need always to have proper apposition of the proximal part, as this gap increase the chance of wire crossing behind the stent, and when going next inflation, you may crush your stent. Actually, in my practice, I'm not removing the gelled wire until third wire. I use third wire for recrossing, as I consider the gelled wire protection and also a marker of in case of side branch occlusion. In addition, the gelled wire is always in the true lumen. And there is also, as mentioned by Dr. Mamas, a rescue technique when you can inflate the small balloon behind the stent. Gelled wire also can work like anchoring, increasing the guide catheter stabilization. And as you can see here in this scene, that I removed the gelled wire after third wire and even balloon recrossing. After wire recrossing here into the distal main vessel, small compliant balloon was used for stent strut dilatation to facilitate stent crossing. Now I'm trying to get a perfect position for second stent implantation with minimal protrusion into the main branch, using also stent enhancement technique here in the right side. Notice also here 3 ONC balloon in the OM1 branch waiting for the kissing. One tip to remember when we are using 6 French guiding catheter for bifurcation PCI, and both stent plus balloon are needed together inside the guiding cast, better to advance your stent before the balloon to avoid stent dislodgement due to friction inside the guiding. This is very important tip to be remembered. And most bifurcation techniques actually can be done with 6 French, except if simultaneous 2 stents are needed, simultaneous kissing stent, which are rarely done nowadays. Now a kissing balloon optimizing using 3 ONC balloon, and also in my practice I'm always inflating sequential balloon inflation, then simultaneous up to the nominal pressure. And now is the time for the second boat using 4/8 the non-compliant balloon. And remember there here we should in the second boat to be slightly more proximal compared to the first boat, because the second boat mainly is for restore the circular shape of the main branch stent rather than the elliptical shape that was ended and expected following the kissing balloon inflations. After that, I did another run of OCT, as you can see here, which showed there is no stent edge dissection, fortunately, good covering of the bifurcation area, as you can see here, with the minimal strut protrusion in the main branch in this view. But in the very proximal part of the main branch stent, some area of stent malposition, as you can see here in 10 to 11 o'clock, and also in this view here in 6 or 5 to 6 o'clock. And malposition is by definition, it will be significant if the distance between stent struts and the basin wall actually is more than 300 micron or more than one strut thickness. On the other hand, if the malposition is less than 250 micron, so this in this situation can be left alone without further dilatation. So here I upsized my NC balloon to 4.5 milli with high pressure inflation to achieve the needed good distal apposition. This is my final angiography with TIMI-3 flow, widely open both branches, OM1 and OM2. And this is my take-home message from this case. Reverse stab is a modification from T-stentic bifurcation technique with first stent deployed in the main branch to side branch. Most bifurcation BCI, as I said before, can be done through radial artery using 6 French guiding. Please use imaging in the bifurcation if it's available in your lab. Be ready to change the initial strategy if needed anytime and according to every bifurcation steps. Use side branch safety wire even in the provisional. Use third wire or double lumen microcatheter for wire recrossing. First port, second port are mandatory. And thank you very much for your attention.
Thank you very much, Dr. Ahmed Abdullah, for this nice case presentation. Now, I will address some questions to my panelists, and I will keep also the two who presented the cases to stay with us, because some questions I'll address to some of you. So if I ask my dear panelists the first question, in provisional stenting, if the side branch is not jeopardized, still kissing balloon is necessary, Professor Mamas? The side branch is not affected or jeopardized, so still the kissing balloon.
I only do routine kissing balloon in one situation, and that's left main PCI. So in left main PCI, I always do final kissing balloon into circumflex with a drug-eluting balloon, because we know that disease will, can progress, and it may progress in 3, 4, 5 years' time. And so I always want to have access into the circumflex. Otherwise, if flow's okay, patient is asymptomatic, no, I don't do final kissing balloon. There is data from the Nordic randomized controlled series of trials where there was no difference in hard clinical endpoints between final kissing and non-final kissing balloons, although there was a difference in angiographic restenosis rates, although this didn't impact on outcomes. So only in left main will I do final kissing balloon.
Dr. Khalid, any comments about the questions? Would you do provisional if the side branch is not jeopardized, or you have a good flow? Would you do provisional?
You mean do final kissing?
Yeah, in a provisional.
Well, in a provisional strategy, I agree with what Dr. Mas just outlined. I'm more likely to do a final kissing with the left main because the circumflex is a major vessel, but in non-left main bifurcations, if the side branch is not compromised, I suffice to do the pot and don't necessarily do a final kiss.
Dr. Abdelmajid, any comments, please? But unmute your microphone. No, the microphone.
Yes, no, I agree with my colleagues. Dr. Musa, if the flow is not compromised on the side branch, then that's that's enough. I don't kiss unless, of course, it's a circumflex, and that's for a future access to.
There is a question that in a professional stenting for left main to LAD, after a few months, many patients come back with a new lesion in the ostium of the left circumflex. Any strategy to prevent this? We'll start with the Professor Mamas, then I will ask the other panelists to comment on this.
Well, it's unusual if the circumflex is absolutely healthy to suddenly get new disease developing in a couple of months. And that's why I think in these sorts of cases, it's mandatory. If you're doing left main, you should do intravascular imaging. If you don't do intravascular imaging, you should not be doing left main. And I think intravascular imaging will then give you information around disease around the ostium, but also importantly, whether you need to kiss, and when you have kissed, whether you've got good expansion, whether you've got a good apposition and so forth. So I think imaging will probably reduce any target vessel revascularization down the line.
Khalid, any comments?
Yeah, actually, this very point was brought up last year when I attended the European Bifurcation Club meeting in Barcelona, and they actually showed some imaging studies that were very interesting and support what we initially said about doing a final kiss when it's the left main and the circumflex, because they did show data in cases where there wasn't this final kiss at the index procedure. Some of these struts that overlay the ostium of the circumflex themselves get endothelialized and contribute to a restenotic event at the ostium of the circumflex. So that's probably another reason why I am, especially with left main, I am more likely almost always to do a final kiss to open those struts and clear the ostium of the circumflex for overlying struts. Because this was actually presented very nicely from a group in Asia showing by IVUS imaging that when this final kiss was not done at the reference procedure, some of these patients came back because of this issue, endothelialization of struts overlying the ostium of the circumflex.
Dr. Abdul-Majid, any comments for that you would like to add?
I think beside the imaging and understanding the lesion you're dealing with, and also optimizing the results, is also the preparation of the lesion. Especially if if you're dealing with the bifurcation and ostial left circumflex, then that preparation of the lesion is very important to avoid such an outcome.
There is a question addressed to Professor Mamas that what about using a stent enhancement or stent boost for localization of second stent in TAP technique? Would you use that when you do TAP?
I always use that. That's an excellent point, and I always do that. I think it's worth taking your time. I've seen cases where the side branch stent is mangled because people do not spend enough time, and think stent boost is an excellent approach in these sorts of cases, but also using stents that are more visible, so cobalt chromium stents rather than regular old-fashioned stainless steel stents.
So to my the other panelist colleagues, which imaging modality is the best in bifurcation? And this is non-left bifurcation. Is the IVUS or the OCT when you would do
the one you have most experience with?
Okay, you agree, Professor Mamas? Abdul-Majid?
Yeah.
Same.
Yeah, yes. I mean, I think, I usually use intravascular ultrasound and, to understand the calcium for the sizing and, for optimizing the results and before the preparation, before dealing with the lesion to prepare the lesion. So I commonly use intravascular ultrasound.
Professor Mamas, there's another question to you here. Shall we leave the gelled wire while we are doing POTS? This might cause more difficulty in jailing. Shall we leave it or we take it and do it?
I generally leave it unless I'm doing DK crush because, I don't know, I've never had problems taking my wires out. And I also like to protect the side branch in case it does go down, that you've got then a means by which you can salvage the situation.
And when you use coated polymer hydrophilic, more resilient to any rupture or fracture would be good when you do such procedures.
Yeah.
The last, The other also related to the pots, how you select the balloon size for pot kissing? What is main branch? Main vessel. Main vessels, Majid?
Yes.
Okay. Before I conclude, there's a question to Dr. Ahmed Qasim. You didn't do a pot in your final, is that, and then no imaging. You know, I hear that you don't have the imaging available. They didn't do any imaging for your case when you did the double tap, Ahmed Qasim.
Yes, unfortunately, we don't have imaging at the time in our lab. But in this situation, when some cases, of course, we're doing complex cases and we accidentally you don't have imaging. So I'm insisted to doing high pressure balloon inflation, reaching very high pressure, even 20, 24 in some cases, even to ensure well apposition. So it is very important, either you have imaging, which of course confirm that you make a well apposition, or if you don't have, so using NC balloon, very high pressure, reaching even up to 20 or 22. This is my practice actually.
So
for bot, I don't bot, but I don't bring in, of course.
Yeah, okay. I have two questions for my panelists. For pharmacological management, would you, in the complex PCI that we have seen using two-stent strategy, would any particular preference of dual antiplatelets? Do you use aspirin Plavix, or you should go to ticagrelor or prasugrel? It's available, Professor Mames?
I don't think, I mean, it depends on the clinical context. So for ACS, I would generally use prasugrel or ticagrelor with favor towards prasugrel. For stable elective, it would be clopidogrel. I think the question to my mind is the duration of antiplatelet therapy, because we certainly know that for more complex cases, there may be a benefit for more prolonged antiplatelet therapy than the conventional, either 6 or 12 months, depending on whether it's elective or ACS.
Khalid, any preference for dual antiplatelet strategy in complex PCI?
No, I think as the Mamas pointed out, I think for complex PCI, it's more the duration rather than the type of antiplatelet to use, whether it's clopidogrel or ticagrelor or prasugrel. That depends more on the clinical presentation, but as far as the complexity of the lesion, I think it has to do more with the duration that you continue the dual antiplatelet therapy rather than type of antiplatelet therapy you use.
Majid, any comment with that, with the strategy? You have any preference for one over the other in dual antiplatelets?
I mean, it goes back, you know, to the clinical and the, you know, the anatomical complexity with it. And with bifurcation, you know, we tend our, you know, our default in most of the cases, we use the ticagrelor as the, you know, as the initial, and then depending on other factors, you know, we move to, you know, to clopidogrel. But also, but they, you know, the challenge is, as my colleague stated, is the duration. You know, how far do you go down the road? You know, you go beyond a year or not. And I think, you know, other factors get the burden of atherosclerosis and chronic disease, and also the risk of the bifurcation itself plays a role there in that decision.
I have last question, and then I will conclude. For the definition 2 trials, you know, they uses the definition complexity. So what about the non-complex bifurcation lesion? So what is the address? Should we use it in every bifurcation lesion, or should we just strictly to definition criteria for complex bifurcation that we should use the 2 strategy? However, if it is non-complex bifurcation, then a professional standing is more than enough. So I'll just hear 1 minute from Professor Mames about this, the definition 2 trial. What is the message that we should?
In my view, it should only be for number 1, true bifurcations, and number 2, complex bifurcations. That's what the risk score was derived from, and that is what the risk score was applied to prospectively. I don't think you can apply the state to simple lesions. Provisional is best in simple lesions.
Dr. Khalid, comment?
Yeah, I would agree with that, with one maybe addition, and that is, and I thought we saw it sort of illustrated in the first case today. There was when you get when you lose flow in the side branch, that even if you're planning for a provisional strategy and there was minimal disease or mild disease in the side branch, but once you have gone down the road, done the pre-dilatation, and even just with the pre-dilatation, you start getting compromised flow in the side branch, even though it may not have met the definition criteria, I think then you're obliged to switch to two-stent strategy. So yes, two-stent strategy I prefer for complex bifurcations, but even simple bifurcations, if you start getting compromise of flow into the side branch after your pre-dilatation, I think you should automatically start thinking of a two-stent strategy. And if you're really worried about losing the side branch, you're getting to be one flow or less in it, then I would switch to a two-stent strategy in which I would start by stenting the side branch to secure it.
Abdul-Majid, would you comment on the definition about the strategy that they are adapting using the complex PCI?
I believe it's a it's a good guide to to help in planning, but as Dr. Imam mentioned in his summary, you have to be ready to change your your plan or your strategy at any time, as we saw in the first case. So it's a good for as a guide for planning, but we have to be flexible depending on the clinical and the situation that we're facing.
The last thing in the definition too, one of the limitations that they have, abrupt closure of the side branch was noticed to be an 8.6% in the professional stenting with about 28 cases. That might contribute to the high risk, the high incidence of target vessel MI. And the other problem, they didn't use the balloon or microcatheter in the jailed wire to restore the side branch. So this is just one of limitation in the bifurcation 2 lesion. I do really apologize for the remaining of those who asked me questions in the question pool. For the time we have passed beyond the 5 minutes beyond the time, I would like really to thank my colleagues, my panelists, Dr. Khalid Shebi from Saudi Arabia, Abdul-Majid Zbeidi from United Arab Emirates. Thank you very much for being our panelists, sharing the information. And thanks to Professor Mames from UK for the nice presentation on the tips, tricks, and for the nice discussion. Also, I'd like to thank Ahmed Qasim for very nice case presentation and evidence base behind it. Ahmed Abdullah also very nice case illustrated. And thank you very much for all of you. And thank for all those who participate in this symposium. And thank you for the sponsoring the ASUNU for sponsoring this activity. So thank you very much and goodbye.
Thank you.
Thank you very much.
Thank you.
Ziad?
Yes, doctor?
Ziad, sorry, Ziad.
Okay, now the audience have to click on leave to go directly to the survey, then they will receive that certificate of attendance.
Okay, just go tell them, okay.
Just
Thank you
click
very
on
much.
leave and you will be directed to the survey.
Do we have to do the survey? I don't see a survey. No, I was really bad.
You're biased, Mamas. You'd be biased.
Yeah, thank you very much. Thank you. Bye-bye.
Okay.
Thank you. Bye-bye.
Thanks, guys.
Thanks.
Bye.
Bye.
Okay.
Ziad,
See you guys.
see you.
Thank you.
Thank you.
شكرا يا موسى.
شكرا حبيبي عبد المجيد. الله يعافيك. شكرا عزيز. شكرا.